Kaveh Sherjani is vice chair in the Department of Medicine at U of T. He works as a general internist as well as Sunnybrook. He was the inaugural director of CQUIPS from 2009 to 2019, and he can tell you what that is. But his research focuses on identifying and further developing effective strategies for achieving improved quality of care. He has more than 160 publications, including patients in leading journals such as New England Journal, Lancet, JAMA. He has held a Canada Research Chair in Patient Safety from 2004 to 2013. He has written a book for the lay public on medical error. And interesting anecdote is when Kaveh was in a residency program, we're a family of doctors, right? Lots of us in the extended family. We were asking him, what do you want to do? What sort of subspecialist do you want to be? And he's like, well, I'm thinking of becoming an academic internist. And we're like, what? Why? Why did you be?
The shame.
And then he said, this was the 90s. He said, I want to do research in medical error. And we're like, what the hell? You're never going to be successful doing research in medical error. Anyway, this is what happened.
Thanks so much, Kham. And thank you so much, really. It's a pleasure to be here to see some familiar faces too, not just Kham's, but also Ken Jin, who I remember as a wonderful attending when I was in the CCU, my second month as an intern, and a few others too. I noticed that I think Steve Nantel is now the head of hematology, and I fondly remember my heme rotation with him. So thanks so much. I'm just going to share screen. It'll take me a minute to fumble through that for a second. Here we go, and then I always have to swap the settings. Is that right? Perfect. Yeah. Okay, so thank you so much. Before I get started, I first gave a version of this talk almost exactly a year ago at a conference in the UK on the need for quality improvement interventions to address the social determinants of health. And I've been gradually evolving and hopefully improving the talk over the past year, but it's still a work in progress. So I'll definitely welcome feedback on the ideas I'm presenting. The main point of the talk, by the way, is to stimulate conversation, not present a definite view about or any of the solutions to the crises we face. Before I go on, I'll just say that I have no actual or potential conflicts to disclose. So the title of the talk refers to reshaping research priorities to match the massive crises we face. I think we all have an idea of what they are, but just to be clear, they include the ongoing SARS-2 COVID pandemic, the near certainty of future pandemics, the existential threats such as collapsing ecosystems and the climate crisis, which I obviously don't need to tell people in British Columbia about, structural violence against racialized groups, worsening income inequality, which is really approaching levels last seen under the feudal era, and the opioid epidemic, which again, I don't need to tell people in BC about, but I think as we all know, the opioid epidemic lowered average life expectancy in parts of Canada and the US even before COVID did so. Now, because of these crises, many have pointed out the importance of not returning to pre-COVID normal. Yet there's been relatively little talk about biomedical research priorities. Why should we be fundamentally reconfiguring society and not considering any changes to our research priority? It is hard to imagine how the main types of basic and translational research we've been conducting or our approaches to healthcare improvement will deliver worthwhile benefits in the face of the adverse health impacts of these massive crises. Why has there been so little questioning of research priorities? Probably because the mainstream view holds that research routinely produces important advances. We're just not very good at making sure they are translated into practice in a consistent and timely enough manner. And this simple diagram also makes clear why in many contexts people refer to diffusion and implementation, knowledge translation, implementation science, and so on, because under this view, all we really need to do is translate the results of research into practice. And I show this citation at the bottom just to make clear that until relatively recently, I shared this mainstream view. But I've come to believe that this view faces two fundamental challenges. First, most improvement strategies don't work when rigorously evaluated, and the ones which do typically confer small improvements or involve narrow aspects of care. Even worse, though, is the second challenge, namely that most clinical interventions also turn out not to work or to confer small benefits with large numbers needed to treat. So they're not even that worth translating into practice anyway. Now, that second claim is obviously more controversial, so I'll first briefly cover the first point. Some of you may remember that over 25 years ago now, there was a systematic review in the CMAJ with this memorable title, No Magic Bullets. This was a systematic review of just over 100 interventions to change professional practice, or what we might now call quality improvement. And the authors concluded that they mostly achieved small to modest gains. And not much has changed in the 25 years since then. The results shown in this, in the bullets here, I chose them because they're all three relatively common ways of improving quality, and they all have relatively recent meta-analyses where they actually reported the percentage of patients receiving desired care and the absolute improvements in those percentages. And you can see they're all about 5%, which I would argue is a drop in the bucket, almost homeopathic. And to appreciate why these results are so disappointing, I'll use the findings from this meta-analysis of computerized decision support, which I was involved in and was published just over a year ago in the BMJ. So this, by computerized decision support, I'm referring to those pop-up alerts that could be as simple as, you know, don't give this antibiotic, the patient has an anaphylactic history of anaphylaxis. Or it could be a little bit, or could be reminding outpatient physicians about some aspect of preventive care, cancer screening, they haven't had their colorectal cancer screening, or inpatient doctors are not on VTE prophylaxis, or it could be more complex decision support like renal dosing of medications. Now, as shown in this forest plot, there were 122 randomized control trials involving 10,790 clinicians and over 1 million patients, and the absolute increase was 5.8%. Now, to see why that's such a small drop in the bucket, a median of 39% already received the desired element of care. So this absolute increase of 5.8, call it 6%, means that 45% of intervention patients received the desired element of care. So over half of patients still did not receive their recommended care. Now, there are more robust examples. Sometimes we do achieve larger successes, like this modification to an order set in the emergency department, nudging clinicians, basically making it harder to order urine cultures and nudging them instead to choose urinalysis with reflex microscopy instead. Now, this simple intervention cut the culture rate roughly in half. That's a nice outcome. It's definitely not a marginal improvement. But first, for every one of these successes, there are multiple failures of the same sort of intervention. And more importantly, this sort of project addresses a very narrow target. We can't keep playing whack-a-mole with dozens and dozens and dozens of these narrow targets of quality improvement. This problem of narrow targets comes up a lot and applies to virtually all the noteworthy successes in quality improvement, just as in the rest of biomedicine. This is a very well-designed and executed intervention that targeted high-risk prescriptions for NSAIDs and antiplatelet agents. The thoughtful, multifaceted intervention was showed a 40% relative reduction in these high-risk prescriptions. You can see that in the middle panel. And on the right-hand panel, you can see what they did, that something that a lot of studies don't do, is they had a 1.5 year, 18-month follow-up period, and you can see that the effect was sustained. But this robust reduction involves a problem that affects only 3.7% of patients, the ones taking the high-risk prescription. Again, we can't keep playing whack-a-mole with so many interventions like this. Someone had to develop a report card to have financial incentives for the doctors to review it and have an informatics database to support this work. And then the practices had to develop improvement strategies for this problem. We can't do that for multiple narrow targets like this. And this final example I'll give highlights that we have the same problem of marginal gains, even when improvement efforts are applied to common chronic diseases where there's been a lot of effort expended. This was a meta-analysis of multiple categories of improvement interventions for type 2 diabetes, which came out in the Lancet almost 10 years ago. I was a senior author on it, but had been the first author on an earlier one in the JAMA a few years before that. But the main point is that across 142 randomized controlled trials of these well-defined categories of improvement improvement interventions, case management, various informatics type of interventions, self-management, and so on, the impact on hemoglobin A1C was a reduction of 0.37%. I think, as we all know, the target is in the 6 to 7% range, but the typical value for people in need of better glycemic control is 8%, sometimes 9 to 10%. So being able to reduce by 0.37% is really only going to help people who are already almost at the target. Now, this was 10 years ago. Maybe a lot has changed, but actually this paper just came out a few months ago in the New England Journal. And as shown here, only 50% of adults with diabetes achieve target control for hemoglobin A1C, blood pressure, or lipids. Only 22% achieve control for all three. So despite numerous advances in new medicines for the treatment of diabetes, the real world impact has been minimal. Okay, so that's the brief overview of the basis for the first point. Most improvement interventions, when rigorously evaluated, turn out not to work or to achieve small gains, and those that produce larger improvements or effect sizes involve very narrow targets. So let's turn to the more controversial second point, namely that the same thing applies to most of clinical research. Now, I realize that the development of COVID vaccines in less than a year gives the impression that biomedical research routinely produces useful solutions to pressing health problems, and that the only issue lies with the delays in dissemination that we've seen with vaccine hesitancy. Yet when one reflects on the typical results reported in major journals, most rigorous evaluations end up showing that potentially promising therapies don't work after all, or they have small effects, often not even on hard clinical outcomes. Here's a study to back up this qualitative impression that we see far more null results than positive ones. This study looked at large cardiovascular trials funded by the NHLBI at the NIH and compared the results before and after the year 2000, when clinical trial registration became common. Once it became harder to report a different primary outcome than had been specified a priori, positive trials fell from 57% to 8%. If you just look at trials published in the New England Journal and JAMA, even with that massive selection bias, the positivity rate is still only 25%. So despite massive investments in cardiovascular research, most therapies, once rigorously evaluated, don't pan out, as with most medical research. Not only do most therapies not pan out, but the minority that do have small effect sizes, even cornerstones of clinical therapy like statins. Among patients with established cardiovascular disease, 33 to 100 patients need to take a statin for 10 years to prevent one CVD death, MI, ischemic stroke, or recurrent ischemic event. And I want to make clear that this summary comes from UpToDate, not some fringe publication taking pot shots at mainstream medicine. The second bullet point comes from an intriguing analytic approach which uses trial data to model Kaplan-Meier survival curves in order to quantify a longevity effect. And you can see that among randomized trials with at least 1,000 patients and at least 2 years of follow-up, statins postpone death by just 10 days in primary prevention trials and 17 days in secondary prevention. Imagine if instead of a vaccine for COVID, we spent billions of dollars a year on a medication that 33 to 100 patients need to take for 10 years in order to prevent one COVID-related hospitalization or death. We are so used to seeing therapeutic effects reported in terms of odds ratios and relative risks, often for disease-specific endpoints, that we forget the rarity of medical interventions that materially improve the length and quality of people's lives. Now, I could give other examples, but instead will make the general point that the primacy of randomized controlled trials in medicine itself reflects the small effects of most of our interventions. The need to ensure the balanced distributions of known and unknown possible confounders and use various forms of blinding reflects the reality that all of the following have larger effects than most medical interventions: chance, psychological effects on patients, clinicians, and outcomes assessors, and confounding socioeconomic factors. Some of you may remember this piece from the BMJ Christmas issue almost 20 years ago. It was a systematic review, obviously tongue-in-cheek, of parachute use to prevent so-called gravitational challenge. And the joke here is supposed to be on rigid EBM advocates calling for randomized controlled trials to evaluate interventions with obvious benefit in observational studies. But the real joke is on the whole of biomedicine for producing so few parachutes that we keep needing randomized controlled trials. So in a nutshell, that's the basis for these two fundamental concerns I have with the mainstream view. Most improvement interventions, when evaluated rigorously, don't work out or achieve marginal gains, and the same turns out for most clinical interventions, so it's not clear what point there is in translating them into practice anyway. But if this were true, surely we would have noticed some concrete signals in population health. In fact, we have numerous such alarming signals. Here is a particularly arresting one, the London Tube map, but with the stations showing average life expectancy for the surrounding neighborhood. As you'll see, the red line has stations with very long life expectancies. Off on the left-hand side, it goes from 90 to 96 years, then 85, and then it drops to 79, whether you go north or further east. It's hard to think of medical interventions that have a 17-year impact on your life expectancy over such a short distance or time, other than public health and living standards, which we've watched be eroded over the past 75 years. I think we all know there are massive economic inequalities. We live in a world where individuals have greater personal wealth than entire countries, but not everyone appreciates the magnitude of the concrete health impacts produced by these socioeconomic disparities. This photo was in the New York Times in September of last year. It contrasts two Chicago neighborhoods with a 30-year difference in life expectancy. And as you can see, the photos indicate that the neighborhood on the left is mostly affluent, white, college-educated people with a median income of $100,000 and houses of median of $500,000 and a life expectancy of 90 years. And on the right, the mostly neighborhood of people of color, lower median income and life expectancy. I think the message here is clear. Now in Canada, even though we don't have quite so egregious disparities or striking a graphic as the one for the London Tube, there have been several studies showing similar results. The Code Red project in Hamilton, a similar one in Sudbury, and actually one in Winnipeg, where I grew up, where there are two neighborhoods with an 18-year gap in life expectancy. This 18-year difference equals the national difference. We'd have to go back to 1940 to have an 18-year lower life expectancy for Canada. Now, the residents living in that poorest neighborhood in Winnipeg are predominantly First Nations, the group which bears the starkest impacts in terms of place of residence and health. I've illustrated that point here with boil water advisories for First Nations communities, but the impact of place applies to many other important health issues, including, for instance, the risk of suicide, which I think most of us know is about threefold higher in First Nations people in general, but 9 times higher for those living on reservations. Now, some of you may have seen this graphic, which the CMA created, maybe in the early 2000s, I think. While one may quibble with the specific percentages assigned to each category, it's hard to argue against the qualitative picture that most biomedical research does not match the major causes of poor health, such as poverty, housing conditions in schools, and nutrition, race, having a disability, neighborhood violence, and other social determinants of health. Now, some people have the reaction, we know this, but at least at some level, but these are socioeconomic problems, not healthcare problems. Maybe, but healthcare consumes about 40% of the provincial budgets. If we keep taking all the money and not doing anything about the social determinants of health, how will we achieve any useful improvements in population health? In fact, I was reminded recently of Rudolf Virchow, the famous German physician and father of modern pathology's famous line that medicine is a social science and politics is nothing but medicine at a larger scale. Okay, maybe so, but these are not really research problems. Well, actually, I would argue that it's not at all clear what the most effective or efficient strategies are for improving the social determinants of health. That's why there have been, for instance, trials of universal basic income. What is clear is that the social determinants of health all have greater impacts on health than do individual biology or the medical therapies that consume most of the massive budgets for healthcare and receive almost all of the fundings for research. What does this sort of research look like? Well, you chose this example, but in previous talks, not just because I'm pretty sure Dr. Palapu is actually a member of the research team that did this, but it's a great study. It's a great example. Some of you may already be familiar with it. This was I guess a clustered randomized trial in 4 Canadian cities involving homeless adults with mental health issues. And the intervention included rent subsidies scattered at in housing across the cities and also offsite case management services. And as you can see that in each of the 4 cities, there was an absolute increase in the days stably housed ranging from 30 to 50%. So this was a really substantial effect. Now, rather than show more examples of what research on the social determinants of health look like, I want to highlight the broader issue of how much biomedical research focuses on targets after the horse has left the barn, so to speak. Last year, also in JAMA, Don Burnett Don Berwick, one of the most prominent leaders in quality improvement, wrote a powerful essay in which he pointed out that except for a few clinical preventive services, most hospitals and physician offices are repair shops trying to correct the damage of causes collectively denoted the social determinants of health. And so I think we all know we need to do more upstream or preventive research. And coincidentally, this book, Upstream, came out last year as well. Some of you may be familiar with the book Switch and Made to Stick by the brothers Chip and Dan Heath. They're management professors at Stanford and Duke, respectively. And Dan Heath's latest book, Upstream, focuses on the problem of making reactive changes as we do in healthcare rather than preventing them as they arise. As he writes, the US healthcare system is designed almost exclusively for reaction. It functions like a giant undo button, but it's hard to find someone in the system whose job it is to address the question, how do we make you healthier? Most agree that an ounce of prevention is worth a pound of cure, but our actions just don't match our words. The book includes a number of substantive and inspiring examples of the hard work of tackling complex problems with direct and indirect effects on people's health. Here's one particularly noteworthy one. That's actually President Obama in the picture at the bottom in the white shirt, attending a meeting of this intervention, which was developed by a nonprofit in Chicago over about a 10-year period, addressing the problem that among racialized young men, homicide claims more lives than the next 9 leading causes of death combined. They realized after doing some analyses of these cases that many of the deaths were not gang related. They were disagreements which escalated rapidly in the context of access to guns and sometimes alcohol and drugs. And the intervention focused on impulse control, conflict resolution, future orientation to reduce crime involvement and foster scholastic success. And in 2 randomized controlled trials, actually I think there's a third now, total arrests went down by substantial amounts, so did violent crime arrests, and high school graduation rates even increased. Here's a related example from Canada, actually from Winnipeg, I believe. The main goal of this pilot randomized trial was to demonstrate just the feasibility of evaluating this complex intervention called the Emergency Department Violence Intervention Program. And they certainly achieved the feasibility goal as they randomized 130 youths presenting to the ED with a violence-related injury. But in addition to feasibility, they also saw some really promising signals of an absolute decrease in 10% of repeat violence related injuries, fewer interactions with the criminal justice system, and they managed to do this without increasing the length of stay in the emergency department. It seems daunting to take on this sort of work at all, never mind outside of a research setting where there's fewer resources for the support that you need. And that's why this story in June was so inspiring in the Globe and Mail. Doctors Louisa Marion Bellemare and Julie Sampson work in Timmins, a mining town in Ontario, where they came to realize they had a higher per capita rate of fatal overdoses that was twice that of Vancouver's and 4 times the provincial average here in Ontario. They noticed a number of obvious shortcomings in terms of basic resources, including that the nearest detox facility was an hour's drive away. The rapid access addiction medicine clinic was only open 3 days a week and required a formal referral. And then police maintained the historic approach of just arresting addicts and letting them languish in lockup without any support for where they went through withdrawal. They gathered the facts, met strategically with different people in the city, and finally made a very impactful presentation to the city council. And through their efforts, and those are the others they engaged, the hospital opened up some detox beds. The RAM clinic is now open 5 days a week and allows drop-ins. And there's even a new police unit that's meant to support this work rather than just arresting people. Now, why have we not tackled the social determinants of health or other prevention-oriented goals? Well, I don't want to dwell on this, but there are obviously lots of reasons. Clinical training prioritizes short-term goals of fixing and curing. Academics also reward short-term signs of impact through relatively easy research and publications that can come quickly. It's also easy to view prevention as someone else's job. There's clearly massive commercial interests in the current approach, and the dominant political ideology emphasizes individual actions and accountability over social forces. I think that this last quote, some of you may remember, to appreciate the significance of what Margaret Thatcher once said, as we all know, there is no such thing as society. It's worthwhile to think about how outraged some of us are when we see anti-science and anti-vax and that sort of thing. Denying the existence of society and social forces is anti-science or science denial at a far larger scale. It fosters a worldview in which individual risky behaviors and individual genes are seen as the only proper targets of biomedical research, even though ample evidence makes clear that social forces have much larger effects on health. Here's an example highlighting how this ideologic preference for individual biology and precision medicine plays out. There are currently 121 agents in clinical trials for the treatment of Alzheimer's. The most likely future outcome is a statin equivalent, a medication which 30 to 100 patients with cognitive decline need to take for one person to derive worthwhile benefit. Why would we not focus on obvious structural problems and how we care for the elderly, having research on better models to care for the elderly in the community, develop and refine new models of long-term care, and of course, optimal staffing levels and payment schemes for healthcare workers in nursing homes. Here's a climate-related example to highlight some of the concrete choices we need to make. The study mentioned in the first bullet came out in the New England Journal toward the end of 2019. Across 652 cities, small changes in the concentration of ambient particulate matter were associated with an incredible detectable changes in all-cause mortality within 48 hours. There was actually a recent Canadian study that was quite elegant, published in the BMJ just last month, showing the mortality impact amongst people who either move from less polluted to more polluted areas or the reverse. And as I'm sure many of you know, there's been increases in ambulance dispatches within an hour of exposure during BC wildfires, similar results in California, and even excess mortality documented in Australia. And the World Health Organization has emphasized over the last few years that the average loss of life expectancy due to air pollution is now slightly higher than that from tobacco. Now, in that context, do we continue to invest mostly in developing more and more inhalers and then conducting trials with endless permutations of LAMAs and LABAs? Or do we balance our research portfolio to include collaboration with those in other sectors to curb sources of pollution and develop strategies for making sure the healthcare system is resilient enough to be able to accommodate what will now become ever increasingly frequent surges of patients during periods of particularly poor air quality? Now, obviously, this will take time, and it's easy to get depressed of thinking how much we need to achieve in the next 10 years or so if we want to avoid catastrophe for much of the population. And in that context, and to avoid despair, I sometimes remind myself of this line: people tend to overestimate what they can accomplish in 1 year, but underestimate what they can accomplish in 5 to 10. The hope that quote brings was brought home to me last year when I read this unusual and extraordinary book, The Ministry for the Future. The author, Kim Stanley Robinson, won basically every major science fiction award for his Mars trilogy. But this is not that sort of science fiction. It takes place now and over the next 30 years, depicting the next several decades of climate politics and action. It opens with horrific depictions of how bad things will be, including a heat wave in India killing 20 million people, as well as various other catastrophes around the world. But then plausibly and inspiringly, it depicts the ways that different people and groups make the necessary changes to various aspects of society. The action includes popular uprisings, eco-terrorism, student debt strikes, geoengineering, and Green New Deal style programs with the post-BJP India leading the way. One terrific aspect of the book is the way it intelligently deals with problems of massive financial inequality and the ideologies of racism and cultural displacement, which have contributed to so many of the crises we face, not just the climate crises. And on that note, that so many of the massive crises we face ultimately have to do with questions of equity and othering, I thought I'd end with this passage from an essay in the Financial Times last year by the novelist and activist Arundhati Roy. She wrote, "Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us, or we can walk through lightly with little luggage, ready to imagine another world and ready to fight for it." With that, I'll say thank you for your attention, and I'm happy to answer any questions. Sorry, I don't know what just happened.
That was a whirlwind.
Sorry about that. If I spoke too quickly, I did want to run out of time.
Any comments or anything? I've got some thoughts, but we've got some respirologists here, cardiologists, any comments or questions before I ask you what can we do in our different subspecialties and in general internal medicine? For example, the Lama lavas versus environmental improvement in our air. How do we move forward and change our research priorities?
I've given this talk a few times, and first of all, it's a great question. It's the obvious question. I don't want to pretend to have the answers. I just think I can't believe more people aren't starting these conversations. We absolutely need to have them. I think there's probably a mixture of things that we can do at major departments of medicine. I mean, some of them are obviously advocating externally. Sometimes we need to, it can't be that every philanthropic person is trying to cure cancer, for God's sakes. It can't, or a new antiplatelet agent, thanks for nothing, right? We need to come up with better targets for our philanthropy. We also need, at places like UBC and U of T, to exert the influence we have through prominent scientists on funders like CIHR. I mean, it's like every so often they'll trot out a little special call, but the reality is something like $600 million of the $1 billion a year is basically going to the historically determined targets of previous research, which is mostly cell biology attempted at sort of not fundamental breakthroughs either. I'm not poo-pooing basic science, by the way. I'm poo-pooing the targets of much of this. So I think that and obviously we have to remove barriers internally. I know that one of my colleagues, who I know Anita knows well, Ahmed Bayoumi, he recently won a research award from the Society for Internal Medicine, Canadian Society of Internal Medicine. I think he made the comment at one point that you can't start talking about these things till you get to sort of mid or senior career. It's too risky for early researchers to do this type of work. It's much easier to get a quick publication on relatively routine sort of research or just describing a problem. But I think we need to do much better job at recognizing what the sort of realistic life cycle of the research that's being proposed is, and how we can encourage, remove some of the barriers that we have, knowingly or unknowingly put in the way of this type of work. I would love to actually hear if Anita does have any comments or thoughts on how to foster more of this type of work, but I didn't want to put you on the spot.
Well, I just want to say, I'm working with the provincial government to bring an exercise or lifestyle measures program to everyone in BC. And we're working our way through it now. It's very slow, but the problem is, what outcomes do I use, and how do I make outcomes in a year when I need 10 years to show outcomes of this? But that's a great example. But I also want to just say, I think that, first of all, I had no idea you were doing that. That is great sort of work. I think that the tendency, because we're starting to see more calls for this type of work, and in general medicine, and then definitely in some of the other subspecialties is relevant too. We should have more social work. There was actually a great piece in CMAJ by family doctors here at U of T. Actually, I don't know them well, but just by reputation, but sort of on a kind of social determinants of health sort of focus. But the reality is, there's only so much you can tell somebody who's overweight, but working two low-paying jobs and is a single mother, whatever the case may be. It's limited impact, especially if they live in a neighborhood that's totally not walkable, this, that, and the other thing. So that's why I think there's not going to be a quick fix, but over the next 10 years, we have to break down more of the silos and work with the school system to have more activity programs, or urban planners to have more walkable neighborhoods, and so on and so forth. I know this may sound, oh my God, nobody's going to go for that. But at the same time, if we just keep continuing the direction we're going on, we are driving off a cliff. I don't know what people think the current focus is going to do in the face of these crises.
It's Ken Jin. Hello.
Hi, Ken.
I'm glad to see that you're such a success. It's amazing.
Because I did so terribly on my cardiology rotation.
No. But you've gone way past cardiology, and I just like to thank you for a really fantastic, philosophically challenging talk. It really makes me think, but it also makes me think, how can we do better? So I send all of my heart attack patients to cardiac rehab, and they're supposed to learn to exercise, but it's been shown that only 20% of people after they've had a heart attack who attend a cardiac rehab program continue to exercise. So how useful is that intervention, which I know would be helpful if people could stick with it. In terms of climate change, I've read that it would cost trillions of dollars, that we can't fix the problem unless we fix India. Then India, their incomes are so low that they are reliant on coal, and they'll never switch to a lower gas producing source unless the West subsidizes them to the tune of billions or trillions of dollars. So some of these things I totally agree with you, but I'm not sure how we as individual people can fix that.
I totally agree, Ken. First of all, thank you for the kind comments and just for being open to even considering these topics. That's why, on the one hand, I hate to give a talk like this and say, oh, I don't know what the answer is, as if I haven't thought about it at all. Really, these are like life-changing, like existential problems that the society is facing. So I guess I want to avoid the hubris of thinking that I'm going to have an answer. But I guess I would say, Ken, I don't want to just give up, but even if I were going to give up, I definitely wouldn't be doing more research on monoclonal antibodies at the same time. Like, what's the point, for God's sakes, right? It's like, why are we continuing to pour money onto these therapies that are mostly having trivial impacts? I think that we need, like, some of the people, instead of, the research community for years has said we need less research, smaller amounts of high quality, impactful research, rather than this proliferate. It's not just predatory journals anymore. It's like all these journals now that you've never heard of. It's not clear if anyone's reading anything anymore. They just seem to be writing papers. But in any case, so some of the work of places like academic medical centers needs to think about, like, to take your field of cardiology, like, to what extent is it worth trying to do more research on a patient level about an exercise program when we could be doing something at a municipal level to encourage more activity, or even for food? Like, obviously, I'm still not sure what the latest evidence is saying on how bad cholesterol is versus refined sugar, but let's just say that we all know that there are massive problems with the typical food that most people are being sort of presented with, and we could be doing more at a preventive level. So I don't know what the answers are, but I think that we need to be thinking about a multi-pronged approach for some of these big problems and work with people in other sectors. But thank you so much for your comments, Ken. I want to make sure there's time for other questions. It looks like there's a hand up from somebody.
And then we'll go to Andy on the hands up. Janet asks, can you comment further on the push for chronic disease management and how we rethink that paradigm?
I don't want to keep sounding like a broken record. Obviously, I did spend a lot of time earlier in my career trying to come up with better models of quality improvement for chronic disease. There's a few problems. So first of all, after 20 years of doing this, we haven't made that much progress. And even if we were to make progress, there's two huge realities we have to think about. First of all, some of these chronic diseases are increasing in prevalence faster than we can, like, improve our that's why I gave the example of diabetes. It's doubly depressing, right? That here on the 100th year anniversary of insulin and in the setting of multiple new oral hypoglycemic drugs, there's been literally no improvement. In fact, that New England Journal paper showed that the glycemic control and blood pressure control actually went down slightly over the last 10 years compared to the aughts, compared to 2000, 2010. So that's happening for diabetes. Like, for God's sakes, what's happening with some other, chronic rheumatologic problems or whatever the case may be, depression and so on. It's not like we have this massive armamentarium of effective antidepressants. So I guess we have to sort of think about and also the reality is the siloed sort of work that general internists always have to deal with. Okay, now they have a chronic disease management program for their heart failure and another one for the diabetes and another one for the depression. So I really am not sure to what extent we can put our eggs in that basket. Like, obviously, we're going to still have to do it, but I think we need to be thinking about prevention a lot more, and some of the upstream or contextual factors like the social determinants of health that probably prevent whatever chronic disease management we were doing, from maybe having its full potential effect. So that's what my thoughts are on that.
I'd like to go to Andy, and before we do that, Kaveh, your brother Shaheen, who is a basic scientist at UBC, is also so you're going to have some problems later. Andy, go ahead.
Well, thank you very much. A very provocative presentation. I think the best way to get a cardiologist to comment is to say that statins are bad. And I think so. I do have a comment and a question. So in cardiology, the mortality rates over the past 2-3 decades have plummeted. Well, more than 60%. And we can argue whether that was statin or smoking cessation or increased exercise or whatever. The simple fact is that we have done something right. And the second thing is my patients who, when I started practicing were kind of in their 60s, now they're in their 80s. And the life expectancy has gone up so far that you kind of start wondering, should we operate on people who are like 95 years old? And we do. And we give them new values, pacemaker, defibrillators, what have you. So some of it is driven by societal needs. Some of it is by our training. And my suggestion here is that the way we see and practice medicine, to change it, you need at least a generation. This is not going to happen, in 2 or 5.
It's so funny. I totally agree with you. Sorry, it's so funny you say that, Andy. But like Max Planck, the Nobel laureate and physicist, once said famously that scientists don't change their mind; they just die, and a new generation comes along. And obviously, he was thinking of Einstein's famous rejection of quantum mechanics. No, I think you're right in many ways, but at the same time, we don't have a generation to wait. And I feel like, yes, then we can debate whether or not the improvements in cardiovascular therapies and so on, and smoking cessation and whatever may have contributed to the obvious increases in life expectancy that we've had. But at the same time, we have to seriously ask, is that what is needed now? Do we need more of that? And I just find that the answer to that, it's hard to believe the answer is
yes. Here then comes the question for you.
Okay, so please.
About 10 years ago, we came up with $4 million, created a chair position in what's called primordial prevention. So looking at the built-up environment, proximity to veggie store, correlation of number of cars and TV sets with cardiovascular mortality. And the person who holds that chair developed that data for Vancouver proper and Lower Mainland. He presented that to us. He presented to city planners. It's all within our public purview. And what happened? Nothing. Nothing got changed. Nothing in any distinguished way. So we know the information now. We may not know if the level of we're dealing with, is it association or is it causality? But normally, as a scientist, you would go the next step and do that study, but there's neither a funding for it nor the interest from cardiovascular community, and that sort of data is languishing, just very much like the stuff that you have shown.
It's a great point, Andy, and I guess I would say that first of all, I want to make clear, I'm not saying that we shouldn't do certain whole types of research, but the targets of those research might need to change. And you've given an example of the type of target that I'm encouraging. I would say that what we still need, the problem that we've always had, which is how do we affect decision makers? How do we make sure that when we do some sort of research that we have a receptor arm for it and something that can be done about it? So, of course I regret, and I can understand why you would even more deeply regret, or any colleague who's seeing this type of work data being generated, nothing being done about it. But you can also understand from a policymaker's perspective, like there's so much research going on all the time. How are they supposed to know this one we really need to do something about? So I think that's why I would say that over the next 10 years, we need to do some serious strategic thinking about how we can pick areas of research that will generate some of the momentum we need, and also, of course, actually generate some useful results. Anyway, thank you so much for your comment. Look, Com, is there another question or comment?
Ken Jin says they want to ban cigarettes.
Oh yeah, I saw that in the Guardian today, Ken. Yeah, they're thinking there's they're going to every year, apparently, for those of you who didn't read the article. I think the current age for smoking is like whatever, I don't know, 14, I can't, whatever the name is, but they're going to keep raising the age so that you're basically being grandfathered in as a smoker, and they're going to make that age of that grandfather progressively increase. Yeah, I don't know. It's hard to know. Like there's always the question about like the reality of like black markets, and are you sort of penalizing people who are sort of hopelessly trapped? They're obviously trying to avoid penalizing people that are hopelessly trapped. And they also apparently have thoughtfully considered the minimum dose of nicotine required to achieve like continued like lack of withdrawal, but at the same time make it likely that people will quit. I do think we need to experiment with things like that. Like, I don't know, what else there is to say. I also think on the physician side, and I hope that this may go over like a lead balloon, but like we've known we need to revamp the fee-for-service system for a long time. Like we can't keep going around doing things like choosing wisely when we know that the reality is like we're basically telling people,
I think we're out of time. No,
yeah. I mean, it's crazy. Like there are a lot of structural things in our own backyard. I mean, even the difference in how we pay different subspecialties. Like we really, after living through this pandemic and seeing so many things turned on their head, we need to be more open to experimenting with these types of things, I think, rather than doing thousands of little experiments achieving unclear benefits.
How about this? I'm interested in what you and Anita think about universal basic income when the small studies that were done in there seemed to show a lot of improvement very early on. What are your thoughts?
So Kaveh, maybe you could speak to what happened in Ontario, which was showing emerging good, but then there was a government change. Perhaps you can speak to that first.
Yeah, it's funny the first Canadian study was actually in Manitoba, and I actually only found out about it a few years ago. It was actually a little known study, Mincombe, I think it was called, in Dauphin, maybe Manitoba, in the early 70s. And I think every adult family received, in modern terms, it was a lot of money. Like it was a lot of money. I can't remember the exact number. I was almost going to say 80,000, but that sounds too much. It might've been $40,000, like for a family of whatever. But what was interesting, the results were lost because a new government came in and didn't want to, most of them believed that it hadn't worked. So they didn't want to throw good money after bad and pay for the evaluation to analyze the data. But they also didn't want to risk being embarrassed that, it was actually effective because it was now a conservative government. And so actually historian found all the data, analyzed it. It was very positive. Doug Ford, what a shock, right? This guy, decided he didn't want universal basic income. There have been experiments, although actually the earliest experiments were in the late 1960s. Actually, sorry, this is a total but fascinating historical tangent. Richard Nixon, of all people, was about to pass a universal basic income law in the United States in the early 70s, pre-Watergate, obviously. And there were multiple studies, like I think 5 from major cities in the United States, all showing benefits. And at the last moment, somebody noticed that the divorce rate went up by 50%. And like at that moment, it tanked in the Senate. Now, what was really painful is that about 10 years later, someone realized that the divorce rate, in fact, hadn't gone up. It was an error in calculations, and it actually remained neutral. But it made a lot of sense, ideologically, that women would no longer feel as trapped. They would feel better able to, get an education, get a job, whatever. But so that was the sad history in the United States. I definitely think we need to do experimentation with this. What's the alternative? We keep having like a whole complicated Band-Aid system of little supports when people get unemployed or this or that. It's such a cross-cutting problem, and the problems of destitution for so many people of working poor now are just so massive. I can't imagine why we wouldn't try to at least experiment more or iteratively refine some pilot programs. Of course, anything that has the chance to do good has the chance to have unintended consequences. I'm not being Pollyannish about it, but I think there have been enough pilots and tests to at least to say that there's not even really equipoise about the idea, but there's probably equipoise about some of the practical considerations. And these things don't always play out the same way in different places. That's a problem that comes up a lot in developmental economics. It's being recognized more and more. Like maybe you finally get your program to help like pregnant women give like a lot less low birth weight babies and so on, and it works in some part of India, and then you try to move it to Bangladesh, and there's an important contextual difference there, right? So that's not just like a developing world or whatever problem. That's a problem in, the same program in Vancouver, Calgary, Winnipeg, and Toronto might have to be very different, or Montreal or whatever. So I do think there's refinements that need it. And it looks like there's a couple other comments or questions maybe.
More cardiology, which is of course the most important specialty. Simple fact of continuing with supervised self-care, which has shown greater adherence to lifestyle management, would be valuable, but we couldn't get funding for it. We need a different funding model.
Yeah, I just wanted to
thank please, Anita.
Yeah, absolutely. I just want to thank you, Kaveh, for giving this talk. It sung to my heart. I mean, this is a space that I've done my research in throughout my career. And the one thing, I just feel like, we are trained to be, as physicians, more individually oriented in the work that we do and very patient focused, which is wonderful. And I think we tend to, being in internal medicine, be very focused on the pathophysiology or the biology or the approach to a patient problem, right? And I think sometimes we shortchange all of those contextual factors that that the guidelines say we should do this, this, and that, but the context of which people live in, and that's the physical and social environments where they get sick or stay healthy. And those things are determined by those social determinants of health that you so nicely displayed. And the one thing over the years is this emerging income inequality, particularly as it affects families with children, because those are the people who have children and children growing up in poverty. And prior to, I think, our poverty reduction program that this province has introduced, we had about a 20 to 25% child poverty rate in this province. And those are, I think I said 10 years ago in a talk, they are our future patients, because all of the issues around physical activity, all the normative health promoting behaviors happen, they get imprinted almost when you're young and they go forward. So this band that we see around your socioeconomic position, it's a huge legacy. It's not to say that people can't move out of it, but it's a huge legacy of what is normative in terms of behavior expectation. And we are very complicated creatures, human beings. And I think it has been challenging in a very biomedicine space to pull in all of those things, because with all of the research that's happening and all of the expectations and the complexity, I feel like the learners, the world is far more complex for them than it was for us. So I also have compassion for them in wanting to be like this, because the overload with social media, with what's going on in our society, it's really hard to manage. And I think in a way, a lot of us tend to put our blinders on because it's hard to manage. But you're right, we don't have a generation. We have to start working together in finding solutions around the upstream. And it's around decision making and political, and where is power and how are decisions made. And you're right, it's not until you get into a senior position that you have some safety, but you can still get pushed over too, right?
Yes.
Like when you don't speak the dominant narrative in situations of power, you get marginalized, right? So it is a fine balance for people, but we do need change. And I am glad that there are people who are more extreme around these issues. We need that because that pulls us, right? So Hopefully. Those are my reflections, but I really appreciated this talk.
Thank you so much. And I know there's never a problem with ending slightly early. So if you want to wrap it up, if there's no other dying, bring.
My question to Barry is there an announcement for next week before we wrap up?
I think this is the last round for the year.
This is a good last round of the year. I think this is great. Thank you. We like to end with someone from Toronto, Kaveh. And